Okay, well, look, thanks very much, Stephen and Emily, for the invitation to come today and talk to you about things north of the border. So I'm very much speaking on behalf of a very, considerable team of people based at the Bondi Centre. Some of the names of those people have already been mentioned already by other presenters this morning. I'd particularly like to acknowledge Jackie Curtis, the Clinical Director of Youth Mental Health in southeastern Sydney, whose passion for this whole area has been an inspiration to all of us in Bondi, as well as to people down here and around the world. Andrew Watkins, who was speaking yesterday at the Equally Well Symposium and telling the story about our experience in Bondi there, and as well as other members of the team who I'll refer to as I move through. My topic is, keep on keeping on, and the idea really that I want to focus on is sustainability and translation into routine care, because we've already heard this morning a couple of great stories about programs, small trials that were effective in terms of bringing the benefits of physical activity, interventions and exercise, as well as multimodal elements to that, into is demonstrating positive outcomes for physical and mental health. But the trick is, of course, how do we take those small project-based trials and see them implemented into clinical practice? And if we do that, do they actually work? So I'm going to try and convince you in the next little while that yes, it is possible to do that. And I'll tell you a little bit about our experiences to some of the things that work. Now, I knew that other presenters were going to already cover off a whole bunch of topics that I would normally cover in the introduction of this, about the life expectancy gap and the metabolic and cardiovascular disease. And I thought rather than repeating that, I'd sort of take a punt that maybe people wouldn't go down this particular path. Oops. And I don't know how to make the slides advance. There we go. Okay, so, and really it's just it's a slightly different focus, which is really just trying to get to the point that actually these physical activity interventions have really widespread effects. It's not just for people living with mental illness. This is some very nice data from a short-term study that was done in a group of healthy college students in the USA. And the concept here was to take students who were physically active and tell them that they were to stop being physically active, to stop their normal exercise for a period of time, and then to look at what happened in terms of their self-rated depression, so the PHQ-9. And what you can see there is that the intervention group here, who are the group who were told, no, you have to inhibit your exercise, you have to be sedentary and inactive, unlike your normal active selves, the PHQ went up, and when they were once again able to perform in their normal physical activity, it went down again. The control group, of course, they didn't change, very much at all. So even, just stopping for a very brief period of time had a measurable impact on the physical well-being of people who didn't have a diagnosed mental illness. And some of the evidence for the potential positive impacts of physical activity, I think, are really just kind of mind-bending, and it really makes you wonder why we don't utilise this as an intervention element more in all aspects of medicine, not just in mental health. I mean, look at what replacing 30 minutes of sedentary behaviour in an elderly population led to in terms of mortality risk. So just changing from sedentary time for 30 minutes into light activity, that's not doing a great deal. I mean, probably me standing here and waving my arms around is probably in the range of light activity. 14% reduction in mortality risk. If you actually change that for moderate to vigorous physical activity, you've got a 50% reduction in mortality risk. Well, that's right, 50, not 15, 50. Now, this is data from an elderly population, 50 and above, 50 to 85, a large cohort. So I'm not saying that everyone in this room, who mostly are younger than that, are going to have that benefit. But it's a really big signal, and it's something that we can really aim to utilise in terms of, I think, helping to motivate both the patients and also the staff to see this as something that's really important. You've already heard some of the data about the benefits in terms of cognitive performance. Alison mentioned that in terms of her talk. Physical inactivity increases the risk of anxiety and also has changes in terms of the C-reactive protein, which we've also seen, which we've also heard about already today. And I guess there is a lot of information out there. This was a piece that Gretchen Reynolds, the health reporter for the New York Times, did a story about one of my colleagues' work, Felipe Schuch in Brazil, who did a large-scale meta-analysis on whether or not exercise can be used as a way of preventing the development of depression. But actually, Simon Rosenbaum, my friend and colleague, looked at people's response to that, and you can see the first one there. If I start exercising, will that make Donald Trump go away? I mean, the reality is that motivation, getting people to do something that is actually that they know is good for them, is really the key, both in the normal population and also, or in the general population, as well as with people living with mental illness challenges. Okay, so what do we know about exercise in people with schizophrenia? And I don't need to go through a lot of this because Alison already covered this very well in her introduction. The study by Joe Firth and colleagues looking at the changes in cognition, improvements in mental health symptoms, and in terms of function. And thankfully, Lauren has already made very strongly the point that I wanted to take up here, which is it's really important to make people aware that these changes occur regardless of change in body mass. And it was fantastic to hear you advocating for this very strong message that we're setting ourselves up to fail if we say that weight loss is going to be the primary deliverable from these physical activity and exercise-based interventions. It is the reason people want to do it. So we have to live with that. That's the reality. That's the expectation. We're not going to turn around that mindset. But we have to convince people, as Lauren outlined, that it's fitness rather than fatness. That is the key thing that we want to do. And I've got some even more scary statistics there about the success rate of people in terms of achieving normal weight. So only 1 in 210 obese men and 1 in 124 obese women will achieve normal weight and sustain it without surgery. I mean, those are the odds. Those are terrible odds. That's why it's so tough in the general population. And I think just this week, there's been a lot of media attention about nutrition and how really we're living in this incredibly obesogenic environment, and that's what we're all working against in terms of trying to maintain a healthy weight in this incredible environment in which we live. So people lose weight and then regain it. Our body, our homeostatic mechanisms are really primed to keep people at that prior body weight, and yet it is the primary motivator for people to start exercise. And there are lots of other reasons. So cardiorespiratory fitness, aerobic fitness is really important in terms of it's a strong and independent predictor of cardiovascular disease and all-cause mortality. Here's Jackie living life as it should be lived on the exercise bike with Alan Rosen, who was the Deputy Mental Health Commissioner in New South Wales when this shot was taken. We've got decreased cardiorespiratory fitness in people living with severe mental illness. It's a big effect size, so it's a large effect size in terms of that reduction in fitness. And even small changes in fitness also make a big difference in terms of all-cause mortality. So you've seen there 13 to 15% decrements in all-cause and cardiovascular-related mortality is associated with a fairly modest improvement in fitness. And amongst people living with SMI, the negative symptoms and BMI and being female is associated with reduced fitness, whilst being in first episode and being an inpatient is associated with higher levels of cardiorespiratory fitness. So you can see that there is and it's possible to change. So these are results from both people living with depression and schizophrenia, and that you can actually get significant change with a fairly brief intervention, like a 12-week program. So that's the mind-body problem reconfigured. You know, we know we need to get moving, we know we need to do something about it, but there is this terrible issue in terms of motivation. And my colleague Davy van Kampvoort from Belgium has put together this really sort of comprehensive story about a whole range of things that have impacts on health-related lifestyle, on fitness, and on physical and muscular strength. So these are, you know, there's multiple factors that we can work on. Physical activity is one of them, sedentary behaviour is another, but sleep, and nutrition and smoking are also going to be really important variables that we need to look at as well. So there has to be some acknowledgement of the scandal of why it's so terrible that we've allowed the physical health of people living with severe mental illness to be so bad, such that people who suffer these disorders have the same life expectancy as the general population did in the middle of last century. It's as though all of the public health benefits of programs to get people moving, to get people eating more healthy, have just not had any impact at all. And instead, some of our medications, some of our treatments, as well as some of the inherent elements of the conditions themselves have contributed to this absolute scandal of premature mortality that Graham Thornycroft so adroitly described in this editorial. And this is a wonderful illustration that Jackie uses frequently, showing this disconnect, that psychiatry somehow became, you know, obsessed with the mind, with everything from the neck up, and somehow whatever was happening, you know, down below was just going to be somebody else's problem, certainly not somebody in the mental health service. And we just have to really reconnect body and mind in order to make sure that that doesn't happen. There are lots of factors, as I said. There's modifiable and non-modifiable factors. We're, of course, focusing on the modifiable factors here in terms of the development of type 2 diabetes. This is Richard Holt's work from Southampton, a nice review that he did a while ago. And, of course, and this is just repeating what people have already said, which is the path to obesity, type 2 diabetes, and early death. You can see that the rates of cardiovascular disease rise exponentially from very early on in the illness or before treatment through to the very, very high rates that you see with people who are ill for some time. And this wonderful illustration from Mario Alvarez's systematic review, we use this slide a lot. I don't always put up a sign saying thank you, Mario, for saying it's okay, but he has said it's okay. But it really was, I think it was critically important in terms of just drawing attention to what people were observing, but not necessarily really, being able to enumerate that was that there's just massive weight gain that occurs during that early phase of treatment with antipsychotics. We kind of knew about what happened later because that was what happened. People went from being on a typical or a first generation medication, they switched over to an atypical and they put on a bit of weight, but it didn't seem too dramatic. But really it was the young people starting off de novo where you saw that massive weight gain. And that meant that we saw that in Bondi as a place where we needed to really start right at the beginning. And so the key element of the development of the Keeping the Body in Mind program is that it came from a gradual recognition of a problem, the trialling and piloting of all sorts of things. One of Jackie's friends had a daughter who was a dietitian, so she came in to try doing some dietary consultations, and guess what? Young people actually liked coming and talking to the dietitian, a whole lot more actually than coming and talking to the psychiatrist or the case manager. So that was like, wow, actually that might work. Same with exercise. I met Simon Rosenbaum, who was a PhD student back in 2010, when I was looking for someone, an exercise physiologist, a profession that I didn't even know existed at that point, to run the exercise elements of a study looking at the effects of exercise on the hippocampus in young people with first episode psychosis. We called it FEP-HEX as opposed to FEP-X. But and guess what? We found that young people were happy to talk about exercise and to participate in that. So in 2013, we got some money from the New South Wales Health Department to actually run this in a more systematic way, to actually employ a team that included a dietitian, an exercise physiologist, a nurse, Andrew Watkins, who had a lot of experience working with first episode clients as a case manager, who had specific interest in training around metabolic health, and also to add in a peer support worker. But it did require culture change. So this was one of the typical meeting rooms in the old building at Bondi where the early psychosis program is based. And after a little bit of work, we were able to turn it into an in-situ gym. So this is that same room. We got rid of the table and the chairs, and we started off with a couple of exercise bikes, but we've now added a full range of exercise equipment. And this is right inside the front door of the Community Health Centre. So reception on the left, on the right, and the gym on the left. It's an integral part. It's not some little cupboard up in the back of somewhere. It's really there as an integral part of the service. It's important to note that it is multidisciplinary. So actually, this is Scott Teasdale, the dietitian with the program, who's just recently finished his PhD and has left the service to go and pursue other academic pursuits in Switzerland. But Scott runs a weekly cooking group with the centre, which is really very, very popular. And he uses this as a way of not just teaching lifestyle change, but life skills, how to go down to the supermarket and learn to read labels so that you can pick the healthy options. I mean, all of the marketing of food is really designed to hide that stuff. Scott helps the young people to see, okay, what do I really need to pay attention to? Not just say healthy option. Is it really a healthy option? How much sodium is there in that product if I'm really trying to cut down on my salt intake? Another element that Lauren has already referred to is the really critical importance of having students on placement. This is so important on so many levels. It's exposing the next generation of exercise physiology students to this as a real career option, that, hey, as well as working in other chronic disease settings around diabetes and cardiovascular disease, hey, mental health, that's another potential line of professional opportunity for me. And the other, just earlier this year in January, I happened to be at Bondi as the EP students showed up for their first orientation, and it's a bit shocking to walk into a community mental health centre and realise that every seat in the waiting room is occupied by an EP student. There's a dozen of them now who come into our service, and we have an orientation. They don't all work in first episode. Some of them are working in the inpatient unit and in other settings, but 12 young EP students coming along to getting their orientation in mental health. I mean, contrast this with 2010 when I didn't even know what an EP was, let alone have one in the service. And the peer wellness coach. I think it was great to have the junior share his story with everybody. And I think there's nothing like that lived experience of someone who's actually had the positive experience. We had a young man, Julio de la Torre, who was a surfer. And in his particular instance, it was the weight gain that came with being on olanzapine. He couldn't surf anymore. One of our treatment team was a keen surfer and helped Julio to lose some weight and get back in with the goal of getting back into the water. And suddenly he was able to do something he loved again, and then to come back into the service as a coach to say to other young people, hey, listen, what these guys are telling you might happen, does happen. And what really happened, and I won't dwell on these results because we've talked about them in many other settings, but basically what we were able to show that this 12-week integrated multidisciplinary program was able to essentially prevent weight gain in the young people who went through the program, as opposed to a comparison group based in Liverpool, in southwestern Sydney, where my other research base is, who didn't have those lifestyle intervention elements. So they put on an average of nearly 8 kilos, and that's absolutely typical. That's not bad treatment. It's a specialised early psychosis intervention program that they have there with psychologists and CBT and low-dose medication and all the things that you should have, but they didn't have the lifestyle stuff. And then you show that weight gain really occurs across the board. Clinically significant weight gain in 75% of the group. But sustainability is what it's really all about. We've now followed that up over 2 years, and really what's very exciting is that with ongoing access to the same intervention elements, that is to ongoing access to coming to the gym, coming to sports group, being able to attend the cooking group and see the dietitian individually if they wanted. Young people took up those intervention elements variably, some of them more than others, but all of them were mostly able to maintain that minimal level of weight loss over a 2-year period. And that was very encouraging because it encouraged our health service to actually adopt this as routine care. So right at the end of the 12-month project, it didn't all fall apart. Simon and Scott didn't have to go off and do something else. They actually had permanent full-time positions in our health service. And what's more, the health service decided, why should this be restricted to Bondi? There are other centres in St George, down near the airport, and Sutherland, even further south, who also have first episode programs. Let's see what happens when we actually roll this out to them as well. We did a staff intervention as part of this, which was, I think, very important in terms of generating the culture change that we needed to happen in those places. But the exciting thing was that when you look at that over time, we're now looking at weight neutrality. So, in fact, people were across the board, across those 3 settings, both males and females, there was essentially no significant weight change in the group. Now, some of those people would already have been on antipsychotics for a while because this was naturalistic now. This was not selecting people as we did in the project who'd only just started on antipsychotics, but people who'd been on antipsychotics for up to 2 years. And as Alison has already highlighted, this kind of intervention works in other places as well. And the work that Joe Firth and Alison did in Manchester is just one example of that. So finally, I'd just like to say a word about extending this to beyond the first episode population into other elements of youth mental health. So what we're now looking at doing is taking this into the at-risk population, and I know that that's already happening given that you've got people coming to Orygen who from the PACE clinic here. And we've started to look at that in our own setting, and I won't dwell on this. This is because Alison's already covered that. So Oscar Lederman, an exercise physiologist who's just finished his PhD with me, has developed a program based around the headspace that's located at Bondi Junction, and we have incorporated a clinical team there that focuses on young people who may not meet criteria for at-risk mental state but are on a potential pathway towards that. We call it the CASPAR team, and he's looked at developing looking at the feasibility and acceptability of a program. It's short-term and targeted towards the chronic disease management plan, where you get free access to at least only 5 sessions with an accredited exercise physiologist or other allied health professionals. So daily gym access in the gym at the community health centre, supervised by an AEP and 4th year students, 5 individual consults, homework and so forth, looking at getting feedback and making sure, as with all of our programs, that it's individualised and meets the person's needs. Oscar's looked at trying to evaluate this, and the primary outcome was the feasibility and acceptability, which he's measured. And essentially, the preliminary results are really quite positive. That is that young people who were referred, most of them, the majority of them actually came and they completed it and they attended quite a large number of sessions. So it does seem to be feasible and acceptable. Interestingly, one of the things that has changed now is that Oscar was on leave for 6 months to finish his thesis and do some other work, and we now have another EP who's stepped into that role. He's only working part-time as opposed to Oscar, who was working full-time. So suddenly the program now has to be kind of fitted in to the days that he's available. And interestingly, the dropout rate has increased, which is not surprising. I mean, if you have to coordinate, and now it's like, okay, Oscar could say, well, what day don't you have after-school activities? Okay, it's Thursday afternoon, I can work with you after school. But Chris can't do that. He only works on Wednesdays and Fridays, so if Thursday's the only day the young person can come, well, that's just not going to work. So those are some of the real-world things that we have to overcome in order to make these programs. Well, even though it looks like it's feasible and acceptable and the outcomes are generally looking positive, I think there's still a lot needs to be done to actually deal with that nitty-gritty stuff that makes the real difference as to whether or not these programs really are accepted and integrated well into routine care. So I'll leave it there. This is the team. Some of the members of the team. You can see Simon in the middle of that group shot there from a wellness walk that has been happening in Sydney every year, where people come together and walk across the Harbour Bridge. Andrew Watkins, myself, and Jackie Curtis there, launching some work that we did with the Mental Health Commission in New South Wales. I have to say, as someone who's been involved with the HEAL Declaration and with the iphYs group, the International Physical Health in Youth stream, since its inception, with the first meeting in Sydney nearly 10 years ago, and also involved with the development of SIMPAC, the physical activity measurement scale that Lauren referred to as being utilised here in Orygen. It was really exciting to hear how these ideas have really come on board and really been taken up here in Orygen. And I really look forward to doing what we can to further sort of support and assist in terms of this, making these programs part of routine care here in Victoria as well. Thanks very much.